So so this is a little different. So it's not Trump for president, whether it's Ulipristal for fibroids. So over the next 15 to 20 minutes, let's see whether we can convince you or whether you can really consider Ulipristal to be one definitive new molecule in our armamentarium as we look forward to the management of fibroids. The story of Ulipristal started around 10 years ago, and the first research molecules were called CDB2914 or VA2914. So that's how molecules are named before you get the chemical name. So those are the research codes. The small molecule, natural product derived drug, highly bound to plasma proteins, 94% binding, and it is a selective progestogen receptor modulator. So whenever you talk about SPRNs, obviously the first thing which comes in the mind is the SERNs, which we are very more familiar with, SERMs through our menopausal medicine days, where we know that selective estrogen receptor modulators play a very important role in our management of menopausal medicine. But this is selective progestogen. We know that it came first as an emergency contraceptive. So the competition was with the existing drug, which was levonorgestrel. That was the gold standard at that time. We had crossed the stage of taking 4 tablets of Oberalgi and all those things. So that was all crossed. So then it was levonorgestrel, single dose or twice daily was what was the gold standard. And Ulipristal came up as a comparison with levonorgestrel with advantages of a 5-day interval or a window period versus a 3-day, and 1 tablet of 30 milligrams taken orally as soon as possible after the unprotected intercourse. The terminal half-life of Ulipristal was noted as 32 hours, and the FDA approval for this indication came in 2010. Coming a little bit to fibroids, that's the Ulipristal story. We'll come back to the Ulipristal story. Coming to fibroids. We knew all the time, but gradually it was becoming more evident and prominent that fibroids have a hormonal influence. So progestogen, we have come to know over time in the research, plays a vital role in promoting uterine fibroid growth. Fibroid cells express functional progestogen and estrogen receptors, and the estrogen receptor binding was twice, and progesterone receptor binding was 3 times higher in fibroid tissue compared to the neighboring myometrium. And the progestogen link with fibroid growth has been fairly well established, where we understand that progestogen has dual actions on fibroid growth. One is increasing the B-cell lymphoma, which is a key protein in the inhibition of apoptosis, causing an anti-apoptotic action, and also decreasing tumor necrosis factor alpha, TNF alpha, which increases, which leads to increased cell proliferation. So, how does Ulipristal act in fibroids, and how does it make a difference? We'll just come to that. But just taking you a little bit through selective progestogen receptor modulators. So we have spoken extensively. We have had extensive talks on SCRNs, but SPRNs are a little different. It's a new class of progesterone receptor ligands displaying tissue selective agonist, antagonist, and mixed activity on target cells. And Ulipristal is the only SPRN approved for the treatment of uterine fibroids, which is our focus today, and we will not be discussing anything else. This is what we will be talking about. The approval came from the European Commission in December 2011 and the Health Canada in June 2013. So how does Ulipristal act on fibroids, and how does it exactly work? So some of you should be able to see it from far. So there are 3 actions, as you will see. One is on the fibroid tissue directly, one is on the endometrium, and one is on the pituitary gland. And on the fibroids, we already mentioned there is a pro-apoptic and an anti-proliferative action, so that helps in the shrinking or decreasing in the size of the fibroids, in the volume and the size. In the endometrium, it has an anti-proliferative action, which induces amenorrhea very fast in a patient with even heavy bleeding. And at the pituitary gland, it decreases LH and FSH levels, causing an inhibition of ovulation, which is another way in which it acts. So it has 3 actions in 3 different parts, and that helps it to work in case of symptomatic fibroids, which we will generally come into. So Ulipristal, sorry for the spelling, in fibroids, the reversible blockade of progestogen receptors binds to progesterone receptors, not estrogen receptors. We've said it's an SPRM, and acts on fibroid cells and not on normal myometrium. Generally, traditionally, we know that the treatment of fibroids as we practice today would be medical management. The reason why we give OC pills or progestins is generally for the control of heavy bleeding, though we know it has limited effect on the fibroid per se. GnRH analogs, yes, does give us some amount of relief, shrinking the fibroid size, helping in the correction of bleeding in sometimes. LNG IUS may be tried in some cases, though they may not be very effective. It's a submucous fibroid or something also intramural. Tranexamic acid is not a proven medicine, but we often use it for any heavy bleeding condition, and one would be fibroids. The surgical treatment, as we know, could be a conservative surgery or myomectomy, uterine artery embolism. We haven't mentioned about the high focus ultrasound, and the hysterectomy, of course, is one of the commonest reasons of hysterectomy is because of symptomatic fibroids. The side effects of the present treatment modalities, what we already mentioned, we know that in GnRH you have a situation where there are low estrogen levels, so a woman will have menopause symptoms. In monthly injections, you can give it for 3 months or 6 months, but we know there's a very high chance of recurrence, so the effect is very transient, and after a year or maybe a year or two, she'll be back to where she started from, and so that it's a very temporary effect of GnRH analogs. COCP's progestogens, there is a chance that it may increase the myoma. We are not very sure what exactly will happen. Still, it's not very clear what exactly the effect will be. Breakthrough bleeding is common. You don't know how long to use it. Tranexamic acid is not approved. Surgical options, all of them have short-term and long-term effects. Uterine artery embolization also has a chance of recurrence, pain, post-embolism syndrome, and it is not universally available. We all know that it needs an intervention radiologist, which are far and few in everywhere. So what is the evidence to support the use of Ulipristal for the treatment of fibroids? And the growing evidence came from Pearl 1, Pearl 2, Pearl 3, and Pearl 4 trials. So what is Pearl 1 and Pearl 2, 3 trials? Let's go through it. What pearls of wisdom can they give us? So this is what Pearl, the full form is PGL4001. That was the name of the molecule, Ulipristal acetate. Efficacy assessment in reduction of symptoms due to uterine leiomyomata. So PEARL. So they really searched for all the letters to get something which sounds nice. So Pearl 1, Pearl 2, Pearl 3, and Pearl 4 is what came out. So just a few words to note here that we're talking about symptomatic leiomyomas, right? So many times we see so many fibroids. We often talk to patients at the age of 45, 1 in 3 would have a fibroid, and most of them would not be symptomatic, so it's not something which you really need to worry about. So here we're talking about reduction of symptoms due to uterine leiomyoma. So where you have symptomatic myomas, that is where this treatment would come in. Something when you're planning a surgery, instead of that, we may have an opportunity to treat them with medicine for some time. So Pearl 1 was published in New England Journal of Medicine 2012, December. And here it is, UPA is, not our UPA, this is Ulipristal acetate. So UPA versus placebo for the fibroid treatment before surgery. So it was a phase 3 randomized controlled trial done in 6 countries, and in women from 18 to 50 year old with symptomatic fibroids who were eligible for surgery, either a myomectomy or a hysterectomy, and they were given daily Ulipristal 5 milligrams in one arm, 10 milligrams in one arm, and placebo in one arm with iron supplements for a period of 3 months. And the follow-up was for 3 months and 6 months. And what did they get from this study? So the efficacy analysis is more or less clear. On the right-hand side, from the red bar diagram, we are showing about the control of uterine bleeding. So in placebo, the control was only 19%, as you would expect. But in Ulipristal 5 and 10 milligram, the control of bleeding was 91 and 92%. About the 20% reduction of fibroid volume was seen with Ulipristal 5 milligram. In 10 milligram, it was 12%. and in placebo there was a 3% increase in fibroid volume. So it was the first initial basic study to show that yes, this works. It is better than placebo. It helps in reduction of bleeding. It helps in reduction of fibroid volume. So here there's another pie diagram of the same study. 41% with fibroid volume reduction of more than 25% seen in the Ulipristal group compared to 18% in the placebo, and 34% women patients with uterine volume reduction of more than 25% seen in the Ulipristal group compared to the placebo. So the conclusions from Pearl 1, which was the initial study, was treatment of Ulipristal effectively controls excessive bleeding due to uterine fibroids and reduces the size of the fibroids. Headache, pain and discomfort or tenderness in the breasts are common side effects. 50% of patients in the 5 mg Ulipristal group became amenorrheic within the first 10 days of treatment. That was one important thing, that if a woman comes to you with heavy bleeding and problems, how long are you taking to get her amenorrheic? And it was 10 days in the 5 mg Ulipristal group. So being encouraged with these results and with this study, it was obvious that we moved one step further, and so from Pearl 1, where Ulipristal versus placebo, emerged Pearl 2. So Pearl 2 was Ulipristal versus GnRH analogs for fibroid treatment before surgery. So we're just moving from placebo to compare it to one of the gold standards at that time, or that time still, a lot of people may say still now, GnRH analogs. So a phase 3 randomized controlled trial, again the same age group of reproductive age group of 18 to 50, women who were symptomatic fibroids eligible for surgery, and here you're having a daily Ulipristal acetate either 5 or 10 mg versus leuprolide is the GnRH analog which they have selected for this study. Leuprolide monthly for 3 months. So this was a balance. So how do they add up and what is the difference do they make? So let's see the results. Here is the efficacy analysis. As you expect, both are very efficacious. They are very useful in reducing. So the PBAC, pictorial blood assessment chart, you can see there was a 90% reduction with Ulipristal 5, 98% in 10, and 89% in leuprolide, very comparable. And the 36% had a reduction of fibroid volume with Ulipristal, 42% with 10, and 53% with leuprolide. So your GnRH analog is working one of the best in reduction of fibroid volume. Then sustained effects seen up to 6 months after treatment cessation. So a lot of questions obviously come that, okay, the drug is working wonders in a short term. What happens after you stop it? How long does the action persist? How long would you be able to, so what's happening there? So Ulipristal, months after the end of treatment, we can see a sustained effect for up to 6 months in this study. Still a 44.6% reduction, but in leuprolide group, they're saying that after 6 months, there's a fibroid regrowth in the end, and there is only 16% who have been retaining the same advantage compared to what is there in Ulipristal. So this is something which Ulipristal scores over GnRH in this case. Then of course came the thing about side effects. Because we know GnRH analog will have a very low estrogen level in the body, so you will have side effects of hot flushes, which obviously was 40% in the GnRH analog group compared to 10% roughly in the Ulipristal group, which was obvious, but they had to bring it down to show that Ulipristal does make a difference and is superior. So the conclusions which came from Pearl 2, so Ulipristal versus GnRH analogs, that oral Ulipristal acetate was non-inferior, not superior but non-inferior to monthly injections of leuprolide in women with symptomatic fibroids before planned surgery and had a better side effect profile. So not that they are similar in action, they do almost the same job, but they are also the side effects of Ulipristal score over GnRH analogs. Excessive bleeding was controlled significantly more rapidly in the Ulipristal acetate group, and amenorrhea induced more rapidly in the 5 mg than leuprolide. So this took 7 days to achieve amenorrhea compared to 21 days in the GnRH analog group. So that took a little more. So encouraged by Pearl 1, encouraged by Pearl 2, so next came Pearl 3. So what was Pearl 3? Pearl 3 was long-term treatment of uterine fibroids with Ulipristal acetate. So now we have short-term gone long-term. What's happening after the treatment is completed? What's happening during the follow-up? So this is a long-term phase 3 open-label trial conducted in 21 investigative centers in 4 countries, 4 treatment periods of 3 months, interspersed with nortristone or placebo for 10 days. So you have 3 months, 10 days gap, 3 months, 10 days gap, 3 months, for similarly 4 treatment periods, and trying to see what's happening and how things are going. So course 1, course 2, course 3, course 4. So here you're seeing a 78% amenorrhea after the first course, which is going up to 90% after course 4. That is one of the endpoints was how much of amenorrhea can you achieve, because this is a woman, symptomatic means pain and bleeding, most of them are bleeding very heavily, so how much of amenorrhea and how fast you can achieve it, which was fairly constant after that. 45% reduction in fibroid volume in the first course and a 72% in the second course. Again, a decrease in the third one. That's another end result which they had found. So the conclusions which they said that yes, Ulipristal is an effective and well-tolerated long-term medical treatment for fibroids, effectively controlling bleeding and pain while reducing fibroid volume and restoring quality of life. Headache and nasopharyngitis were the most common adverse effects. There's no change of ovarian ultrasonography and serum estrogen levels. So those were the other secondary endpoints which they were studying, trying to find out whether there's any change there. There's a transient increase in endometrial thickness in less than 10% women and no cases of hyperplasia. That was another option, another observation of the group. Before we come to Pearl 4, there was another review in between about the pregnancy after Ulipristal treatment of fibroids. So here, if you're doing conservative management, you're having a wide range group of reproductive women from 18 to 50, but sometimes you'd like to find out what happens after the treatment is completed. She still has to pursue her fertility goals. So retrospective analysis of a series of 52 patients who were in Pearl 2 and 3 showed that of the people who wanted to be pregnant, 15 out of 21 who attempted pregnancies succeeded. That's 71%. And of the 18 pregnancies in the 15 women, 12 resulted in the birth of 13 healthy babies and 6 ended in miscarriage. So there were a lot of live births, and there was a lot of pregnancies in women who wanted to be pregnant after treatment of Ulipristal was complete. No regrowth of fibroids during pregnancy was noted in this series which they had seen. So now let's come to Pearl 4. What is Pearl 4? That's the last of the trials which we'll share with you efficacy and safety of repeat use of UPA in fibroids. So you use it for some time, okay, how you use it again, how many times can you use it, and what happens. So the phase 3 multicentric randomized double-blind parallel group long-term trial, 46 study sites across 11 countries, 2 courses of 12-week treatment each. This is what the company now talks to you. This is what you are told today, that you give it for 12 weeks, stop for a month, reassess, and then give it for another 12 weeks. So the entire concept came from a trial. Obviously, that's how already most of the drug regimes come up. So how did they come up with this? It's not that it was magic in their mind. This was what the research has been done. This is what has shown to be useful, and that is what is being taken in clinical practice, and they're expecting us to use. So primary endpoint, percentage age of patients achieving amenorrhea at the end of both treatment courses. So in Ulipristal, it was 61.9, 72.7. Menstruation resumed in most patients after the end of each treatment course within a time period of around a month. So you have amenorrhea, but after stopping treatment in 1 month, you are back. Repeated 12-week course of oral Ulipristal 5 and 10 effectively and safely control bleeding and pain, reduce fibroid volume, and restores quality of life. Compliance with intermittent course is a good symptomatic improvement, and fibroid volume shrinkage can be maintained during the off-treatment periods, which is one of the concerns of a lot of people, that what happens when you're not having the drug. Ulipristal treatment on symptomatic uterine fibroid, the 12-month follow-up. Here, 56 patients between 29 to 47 scheduled for a biomass surgery were included, And after a treatment duration of 3 months, 46.4% opted against the scheduled surgery as had no clinical symptoms of fibroids. Something similar to the Mirena, which we remember when Mirena first came in, there were a lot of people who were similarly. This is something similar there, where you have people on the list, and in 1 year, after 3 months, they say, no, I'm happy without the surgery. In 1/3 follow-up patients, the effect of therapy persisted for the next 9 months. So another thing which we haven't brought up here, which again is important, which will come up in discussion, is how many myomas, size of the myomas, and what was the thing about it. So most of the studies have been showing about multiple myomas. There's not more than one, and again, as I said, it has to be symptomatic. So if it's symptomatic, it has to be intramural or submucous. They haven't specified on that all the time, but obviously, unless it's intramural or submucous, how can it be symptomatic? It can't be a subserous pedunculated fibroid. So that's pretty obvious. Size, most of them have said more than 3 centimeters, less than 10 centimeters. That's where most of the trials have gone. More than 3, less than 10. More than 10 has not been included in any of the Pearl studies. So whatever you have in your clinical practice, you must be juggling around 3 to 10 is what they suggest. And so okay. So I think we're almost finished. So take to clinic points. So take not home. Home is not the place where we do practice. So take to clinic points. Ulipristal acetate, the SPRM, has a potential to radically change our approach to fibroids. There was a time when we said that ওষুধ খেয়ে কিছু হবে না, এগুলো ওষুধের জিনিস নয়, যদি দরকার হয় অপারেশন করতে হবে, অধিকাংশ সময় লাগবে না অপারেশন, কিন্তু that was once we used to say, but now I think times are changed. We may have to change our tune. Symptomatic uterine fibroids may be offered medical treatment before considering surgery. Whether she takes it or not is immaterial. But as a doctor, as a medical practitioner, it's important for us to offer her that this is a treatment available. Yes, you can try it for a few months and see. If she doesn't want it, she wants surgery, fair enough. A lot of people may be interested in a non-surgical approach, and this may be one of them. Evidence strongly suggests benefits, both short-term and long-term, of ulipristal acetate on fibroids, and that is some. So you need to watch this space. We'll have much more discussions in time to come. So we started with Trump for president, and then we said possibly we can look at ulipristal for fibroids, and maybe this is not the first talk on this stuff, but there'll be more talks in the future, and you'll be hearing a lot of ulipristal and fibroids in days to come. Thank you. Thank you.
Thank you very much, Basab, for a short and sweet presentation, giving us the necessary informations. As you can all see from the presentation, there are a few definite advantages of this molecule. You can give it orally, avoids the injection, gives the bleeding control very quickly, initially a finite length of treatment, and we can expect the effect to linger on for some time, giving women some choice, because in the present day and age, medical treatment is all about offering choices to our patients, not dictated to our patients. So they can choose to wait for some time and see if it works long term for them. I'm sure there are some questions, and we better go ahead with the questions right now. We are unfortunate that we don't have Professor B.N. Chakraborty with us. Sir is not well, and our knowledge is no match to his wisdom, but we'll try to discuss as far as possible. Questions from the floor, please.
I have 3 points to what I need to clearance. And that is, what is the total number of patients treated so far? This is number 1. Number 2, does it work in adenomyosis? And number 3, whether it has been tried in fibroadenoma breast.
So first question first, number of patients. In Pearl, we didn't show you the number of patients in each of the things, but on average they were around 500 in each of the Pearls. 500 on average, because we understand it's a multi-centric trial, different centers picking up symptomatic fibroids, but roughly it was around, I think 500 was the total number which we were looking at for Pearl. Use in adenomyosis, use in fibroadenoma. Not yet, because I think we still are in the infancy about getting it well established into the clinical practice for myomas. So I think one step at a time, as you rightly suggest, that myomas, fibroadenomas they have a lot of similar etiology, so possibly one day we may try looking into that. But whatever literature I could cover, I did not get anything yet. So, but yes, we can watch this space, and in future, so definitely may have something. Yes.
How early it could be started after childbirth?
I didn't get that information. Sorry about how early after childbirth. Now, if you look at it, that we're talking about symptomatic myomas. So after childbirth, during breastfeeding, you understand that there will be an effect of amenorrhea to irregular periods because of the breastfeeding. So how much of that would be, if there was a myoma existing at the same time, it's a little murky about, there's not much of trials there. There's not much of observation in that idea, because here we are talking about irregular bleeding due to breastfeeding versus irregular bleeding due to a myoma. But there's no contraindication. You can of course start it, but there's not much of trials to suggest that like you can start it immediately or 6 weeks will be the normal time to start. But there's not much of trials. I'm telling you that it's not it's not contraindicated in breastfeeding. That's putting it simply.
But I think, Basab, you will have to keep one thing in mind, that it's a pretty new molecule.
Yeah, it's a very new molecule.
We don't know about its secretion in the breast milk. So I think I'll be very skeptical.
Very skeptical. I think it's a fair answer. Let's not jump into something exotic. I mean, not exotic, I'll say, but let's not jump into out of the routine scenarios at this stage. Let's look at it in the routine scenarios. So let's look at a normal age group of 35 to 45 when she's completed a family, and I think let's watch the space for situations, as you rightly said, about just breastfeeding. If you look at clinical scenario, there's less chance that during breastfeeding you'll have a myoma problem. That's your last worry at that time. You'll be thinking of other things generally. So, but at the same time, I don't have an answer. So, yes, please.
Basab, have you any experience about, literal experience about cervical fibroid with this drug?
Kalpana, when they're talking about fibroids, they're talking about all kinds of fibroids. And they're talking about symptoms, they're talking about all kinds of symptoms. Especially pain and bleeding and amenorrhea is what they have been studying. So when the cervical fibroid morphologically and constitutionally is no different from a fibroid in another part of the uterus. So there's no reason for it to work differently in a foreign. So it would be working for all fibroids. There's some case reports for intramural fibroids popping out into the uterine cavity and being expelled after use of Ulipristal. So you would understand that it's an intramural one with a submucous component which was heavily symptomatic. If it shrinks to 40%, then it may come into the uterine cavity and may just pop out like a fetal head with the uterus contract. So there have been case reports of something similar to this, which you can imagine is possible. It's not part.
And about the side effect, the headache and the nasopharyngeal, what is the exact cause? Do you know?
No, I would be guessing. Yes, Queen.
It was a lovely presentation. Thank you so much. A few small questions. Less than 3 centimeter, there is no effect? Fibroid less than 3 centimeters? You said 3 to 10.
Yeah, no studies done. The studies, the Pearl group always took out one or more myoma, more than 3 centimeter, less than 10 centimeter. So that was what their studies were. So less than 3, I didn't get much of studies, but it looking logical.
What should we do?
Myoma, no, you always try it. You always try using it. So I think we are free to do whatever we want.
And you spoke about 5 and 10 milligram being used, but it's been advocated that we use only 5 milligram once a day. So in case it's not responding, should we increase the dose, or there is nothing has been said about?
I think again it's. I think most of the studies have shown 5 and 10 not making much of a difference in the total amount of thing. So there's not much of a dosage related thing. So if 5 doesn't work, it's very unlikely that 10 will work. It's unlikely that 10 will work. I think we should shift at something else. Yes?
And pregnancy after usage of Ulipristal, how soon should we, can we advocate?
Like again, they said 1 month for the normal mens to return. So anything after 1 to 2 months should be fair enough, because the drug will be washed out from the body. 32-hour half-life anyway.
Thank you.
Yes, Sundar. Okay, Sundar, please.
Yeah, the studies show that 70% women become amenorrheic after the first cycle of treatment. Estrogen levels were normal, ovaries were normal.
Yes, after the first cycle means after the first 3 months.
First 3 months of
yes.
What I mean to say is that is it possible that you start treatment on somebody, that woman can fall pregnant? If so, Where to go from there?
The contraceptive effect of Ulipristal is not very clearly mentioned. But if you look at the mechanism of action, how it works, there's a very less chance a woman will become pregnant when she is having it. If she becomes pregnant when having it, whether it's got a teratogenic effect or what would be the long term? Anti-progesterone is bad in pregnancy, everybody knows that. So though it's not very clear, but the normal idea of most of the people would be not to keep a pregnancy with the anti-progesterone. But again, it's open to discussion, a new molecule, wait for the research, look at this.
It's still class C drug.
It's still class C drug. Okay, the class, no, but then it was, but you must look at it, when it was used for emergency contraception, it was a single dose, and that is when it was a class C drug. But now with a fibroid use, for a regular use, whether it remains class C is what we need to see. Because I'm not sure, but again, you're giving a much higher dose when you're treating fibroids vis-a-vis an emergency contraception. So I'm not sure what effect it will have as an anti-progestin.
So in effect, should we start a woman in a particular period of the cycle with the drug?
Symptomatic, ideally you are right, but here you're talking about symptomatic woman who is coming here with a very heavy bleeding, she would need immediately treatment, waiting for her the cycle to start. Okay, you're ruling out a pregnancy, but again, you may lose the patient, you may go for somebody else. Yes.
One is, what about the endometrium during the phase of amenorrhea achieved with Ulipristal? And second is, are there any studies comparing the effect of this drug along with Mifepristone, which is also used for fibroids, and SERMs? They are also sometimes used for fibroids.
So, first question, endometrium. I think there was one of those pearls had an effect on the endometrium, which they showed a less than 10% case of endometrium transient change thickness, but not hyperplasia. So that's question. So there is an effect on the endometrium, and this showed the mechanism of action. The endometrium, it should not be highly vascular, it should not affect the endometrium in a negative manner, putting it simply. About use versus Mifepristone versus SERMs, I did not go through any trials. Again, a new molecule, let's wait for the space.
I did use a drug, Ulipristal, for a patient with fibroid, and she's landed on a thickened endometrium, 12.5 millimeters.
It's possible, but not hyperplasia. Means if you do a biopsy for that, it won't come as a simple hyperplasia. It's a thickened endometrium, a transient effect of the medicine which will go. Again, you don't know whether it's due to the endometrium or due to the fibroid that she's bleeding, but yes, it's at the same time it's shown not to be harmful. I mean, there's no effect of going into CA or anything.
Okay, ladies and gentlemen, we have got another talk. We will just have 2 more questions. Ranjit, you have got a question?
Yeah, I was asking about the degenerative fibroids. Degenerating fibroids.
Okay.
That presents not with the bleeding, but with a lot of pain. So, what's the effect? You talked about that.
I think we didn't. I think
most of the second question also. Second question is there any relationship of fixing the dose with body weight? Body weight or the size of the tumor?
The second question, answer first. There is no dose-related response either for the women's body weight or for the fibroids weight. That is not in the trials. Not in trials.
Like 5 or 10?
No, they had no. Whenever there's a research, you understand there are different doses used to find out whether 10 is much better than 5, which wasn't there here. So in that case, 5 is good enough. So that was one. Second is about what was the question?
Degenerative.
So most of the studies, most of the primary and secondary endpoints were directed towards bleeding symptoms. The entire focus was on decreasing bleeding, causing amenorrhea, how fast to amenorrhea, that was the thing. Pain, yes, there were a few studies which addressed pain, some reduction in pain, improving quality of life, but segregation of just pain, just bleeding, I didn't find this thing, but it is a good question.
I think as of now it is difficult to comment on pain in degenerating fibroid because that pain the studies have looked into probably due to excessive bleeding, and when the bleeding reduced, the pain reduced. Basab, just another question from
question?
Yeah, I was just interested to know whether any of us, including Basab, has any experience of using.
Actually, I was waiting for Sir to come. I was depending heavily on Sir to be here.
No, the question is, has any of us used this medicine as a preoperative before doing submucous fibroid dissection, because I've done in few, and it's remarkable.
No, what about the loss of plane or anything like
no, there is loss of plane because the vascularity reduces.
Okay.
And the fibroid really becomes small.
But Kushal,
why I said was it's linked to another question which was raised.
No, but tell me, did you do a pre-op and an intra-op hysteroscopy or a pre-op and intra-op ultrasonography to show the difference?
We always do a 3D ultrasonography before doing a hysteroscopic myomectomy.
So you have two pictures of the effect of on it. How many?
Because we gave the patient was referred with submucous fibroid for infertility patient for resection. We gave Ulipristal for 2 months. 2 months. I never used 10 milligram.
Okay.
So I don't know any of you if you're using 10 milligram or not. So 5 milligram continuously daily, and after 2 months when you do a TBS again, 3D ultrasonography, you really see a shrinkage in size. Now hysteroscopy, you see that the vascularity is so low and it's so easy to resect. But the question I wanted to say was that other question which was raised, that these are the patients who are usually infertile and they are coming for submucous fibroid resection and they are being put on Ulipristal. So it's important to counsel them so that they don't become pregnant during that time. So that is also very important, because in that case it becomes an emotive issue if they become pregnant during. It's almost like becoming pregnant in the HSG cycle. So it's something like that, which all of us have.